Hi, everybody. This is Melanie Headley. You are listening to ToRAISE Questions Doula podcast. I am here with Thérèse Hakoun, the incredible Thérèse Hakoun, the executive director of ToLabor, which is an international training and certifying doula organization. I got it.
You got it. Before we started recording, Melanie's like, what do I say? I haven't done this in a while. I can't remember. But we knew when she pushed record, she would remember. So,
I got it. Yeah. And we talked on the phone recently, and when Thérèse answered the phone, I went into, hi, you're listening to.
Oh, gosh.
I've missed this.
Yes, well, I'm glad you're back.
Me too.
I know everybody else will be glad to hear your voice, not just me.
Oh, I love your voice.
Yeah. So everything well?
Everything's good. Just busy. Babies everywhere.
Yeah.
And I'm waiting on one right now. So if you don't hear me close this episode out, that means I left.
That's it. She's always on the go. I don't really miss those days. I mean, miss them, in some ways, but not the constant on the go. I mean,
yep.
Yeah, I would do it in a heartbeat again, but I'm also glad to kind of be on a little bit of a respite from it.
Yeah.
Too, so
I've been using the hashtag #LifeOnCall all over my text messages, just explaining, I know I said I could do this. Yeah. Well, but now I can't. Hashtag #LifeOnCall.
Yeah. Well, and so anything else you want to talk about before we introduce our guest, or you can tell what we're going to be doing today?
Well, I'm really excited about today. So we are talking to a NICU nurse, a local NICU nurse, and I rarely run into the NICU with being a doula, but when I do, it's a tenuous situation. It's like something's going on that we need to really up the ante of support in that room. And I have been just really so pleasantly surprised lately when I have seen NICU in this hospital where this woman works, and just recently had a birth where baby just needed some help, and then they were just a little bit, and the NICU, I'd overheard one of the NICU docs say, this baby needs his mama. Let's just get that baby right back on mama. And it was like,
that's so nice.
Best.
Yeah.
Thank you. So it's so nice to be able to sit down and ask some questions.
Yeah, and it'll be also interesting to hear. I mean, this is something I think that anybody who is doing births has to be aware of, that this can occur, that a need for a NICU team. And then what is the role of the doula in that situation? And we've gotten that question as well from clients. So I thought, let's just talk. You and I could talk about it, but let's invite somebody who actually does the work. So I'm really looking forward to talking to her as well. So just wanted to remind everybody that we are sponsored by Latch Mama, and we want you to check out their website, latchmama.com, and all their great items. And there's always new ones. They've got great, pretty things right now coming in that they're selling, and there's always new styles, and we just love them. And so please support them yourself, and pass on their name to to your clients and to other people, and get involved in their Facebook page as well. They always have ongoing.
It's a great online community they've created. Yeah,
and their blog and so forth. So we'll be right back. So we are back, and we're here in the studio today, which is nice to have a live person. I mean, I love talking to people on the telephone, but it's great when we actually can sit across from somebody, with Sarah, who is a nurse in the NICU unit at a local hospital here. Hi, Sarah.
Hi, thank you for having me.
Oh, we're really glad as you got to listen to our introduction. We both are looking forward to this conversation, and have you help us in any way you can negotiate the experience of the NICU unit, or what is involved. So give us a little background about who you are, though, and how, you ended up in a NICU unit?
Yeah, well, I've been a nurse for about 3.5 years. I started out not doing anything related to women and children, started out in a cardiac unit. But about 1.5 years in, I knew I wanted to be, in women's and children's health. So that's when I moved to the NICU. So I've been there for a little over 2.5 years. And I couldn't imagine doing anything else. It's a really rewarding but intense job.
It must be intense. And then you have, I know this, you have, not only were you not in a field related to women's health, but you realized you wanted to, you're going further than this, correct?
Yes. So I'm also in graduate school to be a nurse midwife. I'm a little over halfway through. I'm hoping to be done with that in about the next 7 months.
Wow. That is awesome. Another midwife in the making. Yeah, it's really good.
So Therese and I are sharing a mic, so it'll be a little bit of a pause here as we fight over it. But just, Sarah, I know you just took the doula workshop, and you've been training as a midwife. How would you say these two things have impacted your just the way that you practice it as a NICU nurse, or have they?
So it hasn't really changed a lot by the way I practice just because of the role of a NICU nurse, but it has changed the way that I have thought about just the process of birth and babies and what moms experience, at the hospital or wherever they are, and especially the potentially traumatic experience of their babies having to go to the NICU and not being able to do that bonding immediately after birth, and just being separated from their child. That has just really impacted me a lot. It's made me a lot more passionate about the whole process.
That's great, and it was a great question, Melanie. I think that I have no doubt that the people who you're working with are already, you included, compassionate, but you're clinicians also, and I think it's hard sometimes. You're just, I'm sure, in your job and just having to do what you have to do. And, like you said, there's rules and there's protocols and there's things guidelines you have to follow. But anything that enhances that understanding of, anybody who has their baby in the NICU, whether they were prepared for it or unexpected, is going to have a different journey into parenthood, for sure. So, I think I'd just like to start with the beginning of this. Often, and I've been at births as well, where there might be meconium. I'll just use that as the most common reason. Meconium in the fluid. And in many of the situations that I've been in the hospital, that just is an automatic call to the NICU unit. Is that at your hospital?
Always with every meconium birth, we are paged.
Yeah. And so then what happens?
So when we get the page, a nurse, a respiratory therapist, and a doctor will head over to labor and delivery to the room that we are paged to. That could be the OR, or it could just be a labor room. And when we get in there, the nurse and sometimes the doctor will kind of fill us in what's going on, the gestational age of the baby, any other things that we might need to know. And we kind of set up our spot with our warming table and our resuscitation equipment and all that kind of stuff. And usually as soon as the baby is out, they're handed to us, and we kind of take actions appropriately based on if the baby is responding, breathing, or not. A lot of times they usually are, and they're crying, and that's kind of all we have to do. We just have to make sure they make a smooth transition. But a lot of times with meconium aspiration, they're also not doing anything. So that's kind of where we come in.
Mm-hmm. So when you are in the room, are you just standing over in the side waiting for the birth to happen? Or are you doing anything, to participate in that labor or that birth? Or is it just you're hands off until?
We are pretty hands off until the baby comes out. Like I said, we're usually checking equipment and just setting up. So we are kind of just off to the side until that baby is born, and the OB hands them to us.
And how long and how short of a call would you be? I mean, how do I say that? If
like, how long are we waiting?
Yeah. I mean, I know it varies.
It varies. There's times where we can be waiting in there for 20 minutes because sometimes, the nurse is trying to judge. They try and time it perfectly for us to not take too much time away from the NICU, but sometimes it ends up being a while.
Yeah. So, okay, because my experience is that my feeling has been, and Melanie, you have more experience maybe, or no, I guess you said you don't, that I find the NICU unit very invisible in the room. And I think part of the job of the doula at that point is to make that NICU unit less visible, not to be in denial about it, but just not to heighten. Anytime the NICU is called in, I know that the parent and the parents are more concerned at that point. Like, oh no, this is not what I was expecting.
Well, that's something, excuse me, that's something that I think is important to talk about ahead of time with your client too. Just, especially with the meconium, because meconium is pretty common. And so if it's present, it's just a given that there will be some extra people in the room when your baby is born. And as a doula, if that's happening, just to simply say, and here's NICU, they're just here waiting on baby just to see if baby needs help. And, even before then, giving them the spiel of, if baby needs help, baby's going right here in the same room. You can talk to baby can still hear your voice. And if your baby gives us that great big pink up cry, then NICU says, congratulations, and leaves the room.
Yeah.
So it's not so scary if it's happening right, in that moment.
So given what Melanie was talking about, what does happen? I mean, do you ever, I think one of the hard parts for anybody who is planning, a birth is they want their baby as quickly as possible. And a lot of the people we're working with have been prepared to do skin to skin immediately after the baby is born. And that's the delayed cord cutting. If you all are present, is that just like, that's not happening? Are there any options around the possibility of you all working on the baby on the mom, or is it just that's not going to happen?
That's another thing that I've felt very conflicted about, I guess, since the more I've since I did the doula training and becoming a midwife, because as of right now that does not happen, and I really wish that that was something different. If we're in the room and we know we've been called, then I think it's kind of an expectation for the OB to just cut the cord and hand the baby to us so we can work on the baby. And that's something that I would like to see change in the future. But I think as NICU nurses and RTs and neonatologists, we kind of just have it in our head, like, our equipment's over here.
Right.
And if we need to do anything with the baby, it's all over here. And there hasn't really been a lot of thought and change on how we can implement bringing the stuff to the baby rather than bringing the baby to us.
Right. And, I, because of my background in working so much in home birth, we don't have a NICU team in the room. The midwife is the NICU, and I'm the assistant to that midwife. But any kind of work that needs to be oxygenation, a good suctioning it's just normal for us, for them to do it right there on the baby, on the mom, with the cord still intact. I mean, rarely do we have to detach them, unless there's a short cord or there's more need to really get that baby going where the mom can't be holding the baby at that time. So, I mean, I know it can be done in that way,
right.
But I do understand that I prepare people that if you're birthing in the hospital, just what Melanie said, if NICU indeed is called and the baby does need to be worked on, they will separate you, but that it's okay. Like, that's not the end all to end all, is part of what we're also discussing. So I wonder if that's a conversation that can be had with the whole NICU team.
Yeah, it definitely would be a change in thought process for them, the whole team,
and
all of us for sure.
Right.
Yeah.
And I could see where it would not be something that can be guaranteed either, because sometimes you do need that space. I know that, you know, and that concentration. And I think that might be part of it also, is that you got to have everybody on board with what's going on. Like if you have a mother who's holding her baby, that she understand, well, wait a minute, we need to be working on the baby. Or if she's not holding the baby, but the baby is still right there at her on the bed, you can't be grabbing the baby from us until it's time. Yeah. So I can see where it comes from. But I also think there's always that open possibility.
You know, and I also think a lot of that comes from, and I don't mean this in a negative way at all, but fear from nurses and the respiratory therapists and doctors. Just like, what if this is a worst case scenario? I think it's a comfort thing. I think we have everything we need right at our fingertips over here.
Right.
And if this is worst case scenario and we have to go to the extremes, then we have what we need and we know that we're good. So yeah, I think a lot of that mentality of bringing the baby over to the NICU table is just, it's a comfort thing.
Yeah. Do you all come in with your own table?
We don't come in with our own table, but each labor room and each OR has a warming table that has everything that we could ever need.
So you're using the actual warming table that's in the room. Okay. Yeah. I mean, that's been what I've seen, but I just want to clarify.
Yeah, and it's stocked with anything like intubation supplies, emergency medications, all of that stuff.
Right. So you all just walk in with your person, your stethoscopes, your whatever, but everything else is in the room. Even
the stethoscopes will be in the room.
Oh, really?
Yeah. We try to use one stethoscope per baby just for the not passing germs.
Right.
But yeah, so every room will have their own.
Of course. So say this is the experience right now. The baby was born, and say it was the reason you were called into the room was for meconium. So the obstetrician or the midwife hands the baby right off to you all, and then let's say it's not the critical. I mean, you're seeing that the baby is responding. So what happens next? I mean, what are you all doing?
So when the baby is handed to us, we immediately we dry, we stimulate, we kind of assess the baby, like you said. And if we feel the baby's responding, what we say, they're vigorous, they're crying, they're pinking up, we can tell that they're not really in distress. We usually hang out for 5 minutes, so we can have like a 5-minute APGAR score. And then if we feel that the baby is stable and doesn't need to come back with us, we'll usually wrap the baby up, put a hat on it, and give them back to mom.
Okay, so have you done except for stimulating? You're not necessarily suctioning?
We will if we feel like we have to.
Yeah, but it's not like that's a definite.
Not necessarily, no.
Okay. What do you think is the role of the parents at that point? And how could the doula help at that moment?
Yeah, that's something else I've thought a lot about. Kind of like what you said earlier, it just kind of preparing the mom, emotional support, because I mean, as much as you want to not make it a big deal that the NICU team is in the room, I'm sure it's always super traumatic. Like, why are they here? What's wrong with my baby? So I guess just reassurance, and trying not to let the parents jump to the worst case scenario. But as far as the parents' role,
can the other partner be standing there, or is that in interference with you all?
Yeah, a lot of the times the dad will kind of come over and kind of be peeking over our shoulders, looking at their baby, just kind of seeing what's going on, and that's totally fine.
Okay, and then are you saying out loud, like, oh, we see the baby's pinking up? I mean, are they able to hear, or is the doula able to hear what is happening?
Yeah, usually. We're pretty, vocal just because we're working together as a team. So
right.
we are pretty verbal with each other, like what we think is going on or how we are assessing the baby. So
yeah, because I know that one of the roles we tell doulas is never say what you wish is happening or what you hope is happening. Only say what you see or can hear they're saying. Like you can repeat
really
that.
wise.
Yeah, repeat back, because there's always that inclination, I think, in anyone to say everything's okay or it's going to be okay.
Right.
And
but you don't want to say that if you don't know that.
You don't know that. And so that's something I think is really important. So I think if you all are saying out loud, I know for me, many times my job has been to repeat what somebody else, a primary care provider, is saying or a nurse is saying, just because we know clients often aren't listening in the same way that we are. So I think that can be helpful. And it's good to know that the partner is not, somebody like everybody's going, get away.
Right.
Yeah.
Yeah.
I would hope that that's the case. And I also have to say, for fairness, I'm sure there are circumstances where you're going to have different individuals who are going to have different responses. So,
sure.
Yeah, this isn't 100% across the board, but
right.
What we hope and what your experience has been. What if the baby needs to be taken from the room? What if it's for meconium, or what if it's for... Why else would you... Let me ask that first. Why else are you called into the room?
So we are paged for a lot of things. We already talked about meconium. We are paged for prematurity. Anything 35 weeks and under, we will
35
take.
Weeks and under.
Yeah, and sometimes 35 weeks, if they're depending on their weight, then maybe they can stay. But most 35 weekers end up coming back with us. And then any congenital anomalies, heart defects. Sometimes we're paged just because of non-reassuring fetal heart tones, and the nurses or doctors aren't super confident that this baby is going to come out okay. So sometimes it's just a backup kind of thing. But those are probably the main stuff.
Okay. And so I thought that was interesting, though, the prematurity, given that it's 35 weeks, not 30. What happens if some baby is 36 weeks, which is considered premature?
36 weeks can stay over there if they're okay.
Would you be called, though, still in the room?
Not necessarily.
Okay. But at 35 weeks, say, or 34 weeks, is it an automatic, yes, you're coming into the room, and will the baby definitely leave?
So we're definitely coming into the room. 34 weeks, they're going to come back with us.
Okay.
I have seen recently sometimes if depending on the weight, some 35 weekers can stay.
Okay. So definitely at 34 weeks, though, baby will be, no matter how vigorous the baby is or not, the protocol will be to take the baby to the NICU. Okay. That's good to know.
And then how soon can mom join baby after that?
So in babies that are like 34 weeks that are fairly stable, that really don't have a lot going on, they might just need a little bit of help transitioning as far as their breathing and stuff like that. Mom and dad can come as soon as they're ready.
And so they would be under 35 weeks, even if they're vigorous and stable, they would be brought to NICU, not just worked on in the room.
Yeah,
okay.
Just because that's just protocol. And most of the time our 34 weekers are not there for very long at all.
Okay.
And they leave pretty soon.
Okay. And then your NICU unit does have a bed in there for mom as well, right?
We have a couch that does pull out to a bed.
That's nice.
Yeah,
That's
and
really
all
nice.
of the rooms are, private. So that's a really nice thing for parents can spend the night there, because a lot of NICUs don't have that capability. So.
And moms are encouraged to pump and save that milk.
Absolutely.
So I'm trying, when you asked that question, Melanie, which is good, about when can they go, and your response is at any time. If there is a doula there, which is what we hope will be the case, and especially this is for our doulas listening, if the baby is leaving the room, my first question would be, how do you often, and I've talked to doulas who have done this, and I wonder sometimes was that a good thing? I think it's a good thing, but I'm not sure how it works out in the system, where they'll say, can the family see the baby for a moment, or touch the baby, or hold the baby for a moment? What have you had that, or have you all offered that to the family before you leave the room? And what would allow that, and then what would not allow that? I think we know when it wouldn't be allowed, when it's like critical.
Mm-hmm.
But
right.
Is there time, I guess, is my question.
Yeah, so I've noticed that a lot of our NICU team, like when we're over there, if the baby is fairly stable, we do like to try to, bring the baby over to mom for a minute, let her hold, let her kiss, and let dad say hi and stuff like that. And then, we're going to explain what's going on and take them back to the NICU and tell them, you guys just come when you're ready. So unless, like you said, it's very critical, they're unstable, like we're kind of looking at life or death, and, we will try and let them spend at least a couple minutes if we can.
Yeah. What if it is life and death? That feels like it's critical for you all to have the baby, but critical for the family to have the baby in case something really tragic happens, like the baby does not survive.
Mm-hmm.
So is there time in that or is it just you guys we're going?
So it really depends on like that very moment. So there are times where like we'll have a doctor explain, like, I'm sorry, we got to take your baby back to the NICU, like immediately, explain the seriousness of it, and go. And other times we can try and maybe wheel the baby that's in the incubator that is probably intubated or has a mask on their face, and we're providing respiratory support. Then we'll just kind of show them, like, here's your baby. We're sorry. We got to take them back to the NICU.
Okay.
And go.
Yeah, because I think that's one of those moments of, I have no doubt that as sensitive as you might want to be, you're also in that clinician frame of mind of, we just got to really get this baby out of here. I was at a birth one time where there was no reason to anticipate a need for a NICU unit. There wasn't any problems with the heart tones or anything. So the baby was born, and the doctor put the baby right away up on the mom's chest and immediately realized this baby's not okay. Like everyone in the room realized, except for the mom and the other parent. And so NICU was called right away, and they came in and immediately, took the baby and then said, we've got to go. I mean, we really need to work on your baby. It was so fast, and it was so shocking to them because it was was not anticipated, and their baby ended up having a lot of problems. I mean, it was just bizarre that it wasn't known beforehand. It wasn't anybody's fault. It just was what it was. But she was always glad she had that moment of holding her baby before, because it was a long time before she was really able to be with her baby. Under that circumstance, or even the less emergent, what if the partner, like the doula says, I'll stay with her, you go with them? Can the partner leave at that moment and be in the NICU area with you? Is that worthwhile? I mean, I know that they can't be standing right next to you probably at that point, but will they be able to visibly see what's going on or be informed about what's going on?
So sometimes the dad will come back with us, and depending on, again, what's going on with the baby, he might not be able to be, or partner might not be able to be in the room, because there are situations where we're throwing in umbilical lines emergently, just trying to get the baby stable. That's also a sterile procedure. So,
right.
Dad might hang out in the hall.
Can they see it at that point? I mean, is it a glass that they can see, or is it all behind a door, a closed door?
It is a glass door, but there is a curtain, and sometimes the curtain is closed.
Okay. And I understand both reasons for that too. I mean, it could be just way too much for a parent to be able to handle seeing, and in other people's cases, they want to see everything that is going on.
Right. Yeah.
But so if the partner is encouraged and does decide to, or just decides on their own that they want to go to the NICU at the same time as you all are leaving, they can do that, obviously. And you all would inform them, I assume, as soon as possible.
Yes. Yeah, we would definitely inform the partner as soon as possible.
Okay. If they stay in the room and they're told they can come whenever they're ready, is there communication? Because you might have, I don't know your experience, Sarah, but I'm assuming you have a lot of births where the parent doesn't have a doula or a big support system.
Mm-hmm.
And so the baby is born, you all are involved, you leave the room with the baby. Is there communication between, what is transpiring if they're just in their room by themselves?
So a lot of times the labor and delivery nurse that is in charge of the mom will call and say, how's it going over there? Can I bring the parents over?
Okay.
Is this a good time? If it's really emergent and our team feels like, okay, this baby might not make it, we'll call and have the parents come over too if they haven't already. So I do feel like there is communication.
Okay. So it sounds to me also that a doula could say, if she's gotten this good rapport with the labor and delivery nurse, which is what we hope, but also just encourage the parents to ask also the labor and delivery nurse, could you check in with the baby? Is there a way we can find out what's going on with the baby? And if they haven't already done that. And that there's not if the mom wants to get up and go, I know there's going to be some protocols in labor and delivery about stability and those kinds of things. So I can't imagine that they let her go without a huge fight. If immediately there must be at least an hour, I bet you, of stabilization.
Oh, yes.
And checking before.
I would probably say more than that. What's your experience with having the mom come earliest as possible?
In like any situation or in like a critical situation?
Any situation.
Moms have come like pretty we can actually, labor and delivery nurses will actually wheel like their whole bed into their room. So it can be very quick. So even if they've had an epidural and they can't walk yet, that's okay. We can make it work. So
okay.
That's really great to know. I hadn't thought about the bed, coming. So if somebody really wants this, they can be insistent and say, we want to go. And if you have to wheel me in my bed, that's what I want you to do.
Yeah. In our particular NICU rooms, like I said, they're private. It's like a glass sliding door. We can actually open the glass sliding doors completely, not just slide them open, but actually like
flip them open. Yeah.
So we can fit that whole bed in there.
That's great. And so, what I would put out there also to our listeners is become familiar as to what is the NICU unit like. If you can get up there to see it, go, have a conversation about certain things with a NICU personnel, that would be helpful because, Sarah's describing rooms that are very family friendly. There may be other institutions where that is not the case. I know we don't have that in all our local hospitals, I don't think, here as well. So it's going to be a different mode of operation depending on the hospital situation. So then what happens? So, Melanie brought up encouraging pumping, encouraging the parent could stay in. Were you working in the NICU unit before they put beds in? It wasn't always that way, I don't think, or it was.
It was not that long ago that it was still a baby barn.
Right.
If that's what you're asking.
Yeah.
Where all the babies were in the same one big room.
Right. And then, were you there at that time?
That was quite a few years before I got there that we switched.
Which is still not uncommon in certain.
No, we're actually my hospital is the only one in Richmond that has a NICU set up that way. There is another hospital that is following suit in the near future.
Right, working on redesigning. But so I'm wondering how that, and you don't have experience with that, how that impacts their ability, the parents' ability to be with their baby if they can't Have you had any experience at any other hospital, Melanie?
Yeah. Like I said, I usually work at this hospital, so it's nice to, and I've worked with clients who know from the beginning that their babies are going to be spending time in the NICU for, heart defects or things like that. Just they're prepped to have that time there. But yeah, I've definitely gone into the I hate that term, but it's so right, the baby barn of, all of the different cribs in the one big room, and helped clients try to nurse or just do skin to skin with babies. And it's definitely hard. But I think,
are there other mothers?
And there are other mothers in there, other families in there trying to spend time with their babies. But I think the biggest thing that I've taken from my clients who have spent a lot of time in the NICU with their babies, or even a short amount of time, is the relationships that they make with you, with the NICU nurses, and with the other mothers and other families on that floor. For years after, they come back in and bring treats and send pictures and letters. And I think what you do is so important. And just hearing that you going into this job already had so much passion and compassion for what it is that you do and for these families, but now going into another line of work, which really focuses on the holistic well-being of the patient, I think is just going to be even more beneficial to these families that you work with until you become a midwife.
Yeah, that's something that has been really special to me. There's been quite a few families that I've got really close to because their babies were there for months and months and months. And they've kind of become lifelong friends. I still talk to them regularly.
Yeah. That's so nice.
Such a gift. It really is.
That is so nice. And I think you're right, Melanie. I know that from people who have spent time and stories that I've been given the opportunity to listen to. They do get really close to not only the NICU personnel, but also to the other families who are going through this experience. So what is it? I do know somebody who recently in the last year had knew that their baby, they were going to have a premature labor. I mean, that they had already had one in their second pregnancy, and with their third, it was happening as much as nobody wanted it to, and trying to keep her pregnant as long as possible. And she had planned to birth at a certain hospital, but because of the unit not having like the beds, the separate rooms, and the individualized care in that way, chose to switch to the hospital that you're affiliated with. And they spent months there too, and probably got to know you. You're probably one of the ones that they got to know. And what they have said, and other people, is they are so relieved to go home, but it's so hard to leave at the same time because they're so accustomed to this ongoing support and help. And now, as excited and as overjoyed they are that this means the baby's well enough to go home, they're leaving this community behind. So it doesn't surprise me that they want to stay in contact. But what does make me feel good is knowing that you stay in contact too, I
think I know the family that you're talking about.
Yeah. So that they don't feel like, boom, it's all gone for them, because that has been their main support system.
Right.
Yeah.
And a lot of moms say that, as the NICU nurses, we kind of like to be what we call teams. Like a baby will have a primary nurse. And so every time that nurse is on, she takes care of that baby. And the baby will also have other nurses who are part of their, what we used to say, team. So you kind of get a continuity of care. And a lot of moms say, like, you guys know my baby just as well as I do.
Right.
And no one else does other than me and my partner and you guys. And so, they've expressed that sometimes it's scary going home. At that point.
So when a family does have to have a baby in the NICU unit for an extended period of time, whether it be 24 hours or months, I guess you've seen the gamut, though, of people who are there all the time and people who are rarely there.
Mm-hmm.
Is that true?
Yes. Mm-hmm.
And so what is the norm, though? I mean, to put it in kind of that average, what would be the amount of time that you see people spending there? Because we know there are going to be some who are they can't leave except for when they're made to leave by somebody. And then there are those who barely get there.
So for parents, at the hospital that I work at specifically, I think because of the population that we see, a lot of parents are not there and not involved. Is that what you're asking? But we do, so like the normal average, I would say, it's parents come in a few times a week involved. They like to be there for what we call rounds in the mornings, where the doctors and the whole team rounds, talks about what's going on with the baby and what the plan is. So I would say that's a normal.
Hold on one second, Sarah. So Melanie is interrupting us to say she is leaving. So
thank you so much for coming and talking to us today. I've learned a lot, and I've really enjoyed hearing your perspective. And I would say I hope to see you soon, but I don't. But if I do, I will wave at you from the bedside and say thank you so much for your work. And I'll talk to you soon. Thanks for listening, everybody. And I hope that you'll hear my voice again soon.
Thanks, Melanie. Have a good experience. I'm sure it will be. Be careful. So I assume that some of the people can't come because of life circumstances.
Yes.
Like they don't have transportation.
Absolutely.
They don't have, or they can't get time off of work.
Mm-hmm.
And I think that's something really important that we need to bring up is that, I have worked with some people who it's just not possible for them to be there all the time. And it's heartbreaking to them. What they don't need is anybody pushing that in their face of making them feel any more
worse
guilty.
Than they already do.
Exactly. And yet there are others who are unsure about when should they come? How often should they be there? So it sounds to me like a good idea is that if they have limited time to come, that being there during the rounds. Mm-hmm. So do you have late day rounds also, or is it just early morning?
We do. We also have sign out rounds when the team that's coming on for the night shift will kind of get the scoop on what's going on with each baby, but it's a little bit different than our morning daytime rounds, because the daytime rounds, it's much more detailed. Everyone is like putting together their thoughts. We have dietitians, we have social work, and obviously our doctors and respiratory therapists. So that one is usually like the more important one, and that's time for parents to ask questions and
really they'll be
understand.
Given that time to,
yes.
Okay.
We encourage parents to be involved if they're there. We want them to come out in the hall and be a part of it. We value their perspective. They know their child better than anybody else. So,
and they need to know because they're going to go home, and also just what is happening to my child while I'm not here. So it sounds to me a role of the doula can be really to encourage that family to find out when is that round taking place where they can be more involved.
Absolutely.
Yeah. And then if early morning, and are we talking, what are your early morning rounds? I mean, your morning rounds
rounds start at 9 and they usually last, depending on how many babies we have, it lasts a few hours.
Okay. So that could be a hindrance to some people, though, who have to go to a job of being able to be there. So I guess the second part would be to come as soon as they could after their work day or into the evening. They're still going to, I mean, they could come 24 hours, I would assume.
Absolutely.
Yeah.
Yes.
So if they could make it there, they're still going to get filled in by the night team as to what has transpired during the day and what we're doing tonight and all of that. Correct?
Yep.
So what about skin to skin? What about breastfeeding and pumping? And when is it when are they able to do things?
When breastfeeding and pumping and skin to skin is an option, we love it. It's something that I've really appreciated about the hospital that I work at. We really are trying to become baby friendly. We know the research of the benefits that skin to skin and breast milk and all that stuff provides. So we're huge advocates for that. There are, unfortunately, cases where the babies are, especially our little ones, like micro preemies, that are just too unstable, that getting them out of the bed would potentially send them over the edge to a very bad place. So there are rare cases where we can't do that, but when we can, it's a beautiful thing.
So what happens? How does it work?
Well, we would have the mom come in the room, just pull up a chair next to the baby's bed. Depending what the baby has going on, we usually have one nurse or two nurses, or a nurse and a respiratory therapist help us get the baby out of the bed. We'll have mom, usually wear like a hospital gown or something that's open the front, or she can just, open her shirt, and we'll just lay baby on her chest. Baby will stay on the monitor so we can monitor them and like constantly see what's going on. And we like to say that to do skin to skin for at least an hour, just because that's better for the baby, because getting in and out of the bed for those ones are kind of stressful. Yeah. So if they can, at least stay in mom's chest for an hour, that's the best.
Okay, that's great. And what I remember reading, this is decades ago now, when they were, and they called it kangaroo care. Yeah. The research was that babies who are held that way, their recovery actually has been documented as better than those who don't get that kind of touch, which is why we want to encourage people to be there, but also don't want someone to feel guilty when they can't, for whatever reason they feel they can't be there. But ideally, we want that minimum of 1 hour of that holding of the baby if possible. And then when, because we definitely, in most of our cases want to be encouraging breastfeeding. So the baby is now gone from the mom, from the labor and delivery room. We're going to go back there for a second. So there's not going to be putting the baby to the breast right away. So how soon have you seen, are you aware of when they start pumping? And will the hospital provide that pump for them?
Yes, the hospital will provide that pump for them. I've seen some moms who have been very aware and educated by their nurses about pumping immediately, every 2 to 3 hours, and staying on top of it. And if that is being done and they're, starting to get that colostrum to come in, a lot of times the mother baby nurses will actually bring the NICU team the milk, and if we can use it, if the baby is eating, we will. If we can't, then if the baby's not at that place yet, then we'll put it in a freezer. We have a freezer on our floor that is for breast milk, so every baby's breast milk can go in there.
That's great. And so I know, again, I'm asking you broad questions, but what is the criteria of being able to take the colostrum and not being able to take the colostrum? And when is it decided that it is it's okay for the baby to be allowed to, one, get the supplement, get the pumped milk versus them being put on the breast?
So if I'm getting your question right, and there's so many factors that go into this. I guess I'll start off with our little tiny babies. A lot of them, or if they're very sick, they eating at all, whether through a feeding tube or it just isn't an option. Especially if they're intubated and they're on a bunch of medications that would prevent them from doing so, because it would actually be unsafe to feed them. Right. Okay. Then we have our older babies. So
hold on to that for 1 second. So those babies, the mom can be pumping. It'll be stored for future, but it's not. It doesn't mean she shouldn't be pumping. It just means we can't use it right now. Right. But we'll store it for you. And when it's time, we hope we'll be able to provide this. Yes. Just keep pumping. Absolutely. Okay. So then go to your next one.
So then we have, older babies or babies who are just getting bigger and are starting to eat, but they're still premature. So eating with a bottle or latching, their brain just hasn't developed enough to understand how to do that. So we can feed them with a feeding tube, which they would probably have for a while. So we can use that breast milk and it's a tube that either goes in their nose or their mouth. It just goes into their stomach, and we can feed them that way, and they can still get the colostrum. That can still, prime the gut. It's so good for them.
Yeah.
The health benefits of breast milk versus formula is incredible. And so we have that option for quite a long time, and then hopefully they will graduate to being able to bottle feed and be put to breast and stuff like that.
Okay. And is there a difference in your experience between a baby's health, status at the moment, and maybe you might need to get me to clarify this. Is it harder for them to nurse than it is to take something from the bottle? So, for instance, if somebody's been pumping and you all feel like it is okay for the baby to receive breast milk now, not via a tube, but actually through a nipple. Mm-hmm. Is there a difference between artificial nipple and mother nipple as far as energy expended?
There's different perspectives and opinions on this, and I like to say that there is, and the only reason I think I'm coming from a different perspective because of my background, but with premature babies, a lot of times a regular bottle or a breast, especially if the mom's milk has really come in, it's a lot of milk at once, and they're just learning to eat.
Right.
And they are just learning that reflex in the sucking. And so sometimes they need very specialized nipples to be able to eat without choking and
that makes
just
sense.
drooling, and because their brain just hasn't gotten that far, and so they it's not a natural thing for them.
So in that case, the baby would be put on a bottle.
Usually.
It can be breast milk though, but it's just to help that baby learn how to suck and be able to get enough in without it being an explosion for them as well.
We call it like slow flow or ultra preemie, Dr. Brown nipple, stuff like that. Yeah.
Okay, good. And then what we hope is eventually they're graduating up into being able to actually go to the breast.
Yes.
I know, having been at births that are not related to NICU in any way, but babies who are potentially exhibiting hypoglycemic fall, that if they're at the breast, it's too much. Their energy level for sucking is much greater than if they were sucking on a bottle. Like, we have to take the baby. We want the baby to get that colostrum because it helps with the balance. But if they are sucking so vigorously, it can make their body go into a deeper decline faster. So I wonder, I was thinking about that with these little ones also, that it makes them burn so much energy and they could have a dip just from that.
Yes, that's absolutely true.
Yeah.
Yeah.
And then, of course, you're going to have people who just aren't going to pump and are going to, their plan was to do formula, or now that this is what's happening and they can't be here all the time.
Right.
And then you're just supporting those people, I guess, with their decision.
Yes. Yeah, absolutely. And we have lots of different formulas based on different babies' needs. And that's okay. We don't ever want anyone to feel guilty for not wanting to pump and breastfeed.
Right. I'm trying to think. Are there any other circumstances that you want to talk about as far as what, I guess the last thing I want to bring up is, what if the baby really is a baby who is not going to survive? How is that? How do you all negotiate that with the family? And I think it would be something we need to hear about as doulas, on how to be supportive of this experience, because I'm sure Sarah, you've had, I hope not many, but you've had experiences where these babies don't survive.
I have, yeah. I've had quite a few. It is really traumatic for everybody. Let me just say, it doesn't matter how many, as a NICU professional, it doesn't matter how many times you've been through it. It's still just as painful as the first time. But I have found that we have some doctors and some nurses and palliative care teams that have just been so sensitive and so incredible in their support for the parents. And also a lot of it has to do with what the parents want. You know, that's talking to them about, do you want us to go all the way and do literally everything we can to try and save your baby? Or if we're at this point, like, or do you just want to hold your baby? And we'll stop everything because this is where we see this going. And do you just want to hold your baby?
What a hard, not only conversation, but decision for a family to have to make. And I'm sure for some it's crystal clear, and for others it's like, I don't know.
Yeah. It's unimaginable.
Yeah.
But it also is a privilege to be the ones walking through that with the families. And our team is really supportive for whatever they decide. Because if they want to go all the way, then like we get that. You want to give your baby every chance that they have to survive, and you can, say like, I literally did everything I could.
Has that been hard for you at times to see that, knowing, like, this is me speaking, like, has it been hard for you at times to want to continue to do work on the baby that you feel like is just not going to change the outcome?
Sometimes it is. I think coming from a medical background, I can see things that some parents don't, and that's okay. But I totally understand and respect their decision. But sometimes it is hard because as the nurse caring for that baby, I can tell that they're suffering. It's just really hard to watch. But I don't, respect their decision any less.
I appreciate you answering that question, because I have no doubt that you have to respect and understand and do what they feel is right.
Right. And I can't say, like, if that was me in their shoes.
Exactly. You have no idea.
Say the same thing.
Yeah, you really don't know until you're in that moment what you would do. But yes, that would be hard for me, I think, myself, having no experience like you as a clinician, just to think, oh, just hold your baby. Just love on this baby right now and let the baby die on their own terms. But that's that big, that's a societal question as well, and conversation, and about the elderly as well, or terminal of any kind. So I totally understand. What are, for you as a NICU nurse, given the fact that you are always working with babies who have some special need to be in an intensive care unit, how does that affect you personally, if you don't mind me asking you?
Just like in my everyday life?
Yeah.
I think that it has made me a more sensitive person. I think I've become more aware of people's needs. One of the biggest things is it's shown me what a gift life is, and healthy babies. And I think it helps me not, it sounds cliche, but it doesn't help.
No.
It allows me to just not take life for granted as much.
That's, which is really, I mean, you're facing the ultimate there. But often I think that's wonderful, Sarah, because often it's our own life crisis that makes us get to that place. So if you can have it, seeing it through other people's life crises, that's really, really wonderful. Do you have, though, days, the times after a birth where the baby does not survive? I mean, what is your self-care?
I, a lot of times, seem to try and hold it in at work because, you still got to get through the work day. But, I'll text my husband and I'll say, it's been a bad day. Like, I'm going to need, support when I get home. And I usually have to have a good cry at some point. I try not to let this job harden my heart at all, just because I have seen so much. I don't ever want to become immune to the pain and suffering that these families are going through. So, I usually need to talk about it.
Do you share that with other personnel, other people that you work with?
Yeah, I do have a couple of really close friends at work that I'm really thankful for, that we can just talk about it together.
That's good.
And we all understand.
Yeah.
No one gets it better than, another NICU nurse. So.
Yeah, because that I have known other NICU nurses. I've known pediatric intensive care nurses as well. And not that it sounds so terrible to say, but when you're working with babies, there is a difference. When you're working with children, in our hearts, it's like that just isn't the natural course of life. We expect when you get older, you'll have, death in front of you, but we don't want to see little babies or little children. So I know it must the emotional aspect of it would be a huge, I think that's why a lot of people don't choose to work in that department, because it's just too heartbreaking. It's too hard.
Yeah. It's an emotional toll for sure.
Yeah.
But like I said earlier, I have yet to find a job more rewarding. So, or to see a job that would be more rewarding than that. So, I mean, it is a gift. These families really do allow you to come into their lives as their family in that time that they're there.
Mm-hmm.
And, yeah, you're a part of it just as much as they are.
I think for doulas listening, I think what I'm hearing is you can work with a NICU team very well. Just know your role and encourage really the parent to be the one who is doing the communicating. But that my feeling is, though you're on spot emergent clinicians, like, okay, boom, 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 and that's what we want, like the emergency room situation.
Mm-hmm.
You also are compassionate, caring people. And I love the idea of a whole team, that there's there's you, the nurse, there's the perinatologist, there's the respiratory therapist. I like that there's a social worker involved. Can people get counseling if they need counseling?
Yes, we have a chaplain that is trained in counseling that can come to us. Like he might work on like be there for the pediatric floors, but he is in the NICU a lot. And they're there whenever you need them, 24/7.
And it sounds like, depending, of course, on the institution, how it's going to be set up, there is this encouragement for parents to be involved, and that there are certain things that can't be done at certain times, but communication. So as doulas, encouraging that communication and, helping with rides, if that's what's the hindrance is, or helping them figure out alternate plans if it's work related. What can you do to follow through? I mean, it may be much more than you thought, or you're helping set up the resources for them, like ride shares, or
our social worker is amazing at that. She will help parents arrange rides.
That's great.
Doesn't matter if you live 2 hours away, like she'll help you get there.
Yeah, because you live in your work is in inner city, where I guess I know my experience going to that hospital. I meet people from all over the state that come.
Yes, because since we are a higher level NICU, we get a lot of babies from community hospitals, like all over Virginia, really.
That get transported in.
Yeah, that get transported in. If you live more, in
the western,
western part of the state, then they'll go
to UVA. Okay.
Right.
Yeah, so that's another big consideration, is that these people often can't be driving back and forth, no matter how close or far away they may be.
Which that brings up another point. We have a hospitality house for those families that do live a certain distance away, that they can stay at.
That's great.
Overnight, if they don't want to spend the night in the NICU and actually get like a good night's sleep.
And that's something that exists in other communities, obviously not everywhere, but something that as a resource person, our listeners could be looking into and finding out, does it exist? What are the, conditions around being able to stay there for how long? And if that doesn't exist, are there other alternatives for people who need a place to stay. And it doesn't mean you have to house them unless that's something you feel you can do. But are there other opportunities for homestays or something for people to have a break from that hospital setting? Any other last thoughts, Sarah?
I was thinking about this morning, if there's anything, that was on my heart that I wanted to share about this. And I was just thinking from a doula perspective and seeing this as a NICU nurse, there really is a gap with moms that, and parents that are just, that their babies are going to be in the NICU for a while and they are not going to be able to take their baby home. And it's going to be a different transition for them. And I do think that there is kind of a lack of resources, for those parents, just because it's not the norm. It's not that they were expecting. It's traumatic. And I was thinking about this more, and we actually had a mom who had a baby that was in our NICU for almost a year. And she came up with this incredible idea of making little gift bags that had like resources in it, or books, a hat for their baby, like just a bunch of like things in there that she brought to us, and we put one in each room. We didn't have many, so it didn't last long, but just that little gesture for those parents that got those, I think was huge. I think it made them feel less alone. I think it helped normalize the situation for what it was a little bit better. And so I was just going off of that and thinking, well, as doulas and even as midwives, like what can we do to help that transition for parents, because it's not normal and it's scary.
And though the social worker is there and will help negotiate, there's limited time also, all of that. I think, so an idea sounds like helping create resources, knowing what those are that could be available. Like what kind of resources do you think were in that packet of stuff that she was sharing?
I didn't look at super closely, but I know that she had somehow built like a community online of other NICU moms that were kind of going through the same thing. There are like support groups out there. I think she put little stories in there, maybe of some success stories, encouragement stories, stuff like that. I think there was a coloring book in there just to give some parents something to do, so little things like that.
Yeah, so that's something that you all could consider, as well as creating a project of maybe having that fill in that gap, like you said, Sarah, because nobody wants to expect this. Some people do have the expectation because they've been forewarned of it, but that doesn't still make it any less traumatic for them.
Right.
I mean, I've known, people who knew that their baby was going to be born with a certain anomaly and that their baby was going to need to be in the NICU for an extended period of time. So yes, they had preparation, but nobody can prepare really for that emotionally until you're right in the moment of it and you see your baby, and then the variables that can be as a result of whatever that anomaly is. So I think, a doula could be that hand out there, that heart out there, that ear out there, but you don't have to be the only one. There can be others. And I do think, some people want to talk to other people who are going through the same kind of circumstance, like pairing them up with or introducing them to other NICU families to be able to share with. And others, that's not their thing. So respecting also what their needs are. But I think it's important to remind them that there is help right through the facility. Every NICU unit's going to have very similar to what you all have, I believe, as far as the resources immediately available.
Right.
Yeah.
And also for doulas, when I took the doula training with you guys, we talked a lot about, the follow-up after birth. And I was thinking, wow, how important is that? It's so important for moms that are in the NICU that probably aren't home with their babies.
That's
yet.
right.
Like, I'm sure that moms that have babies in the NICU have a wildly higher rate of postpartum depression.
I would
and
assume
all that kind of stuff. So
yeah,
I feel like ongoing, support and like evaluation with those moms is huge.
Yeah, and that's where a postpartum doula can also come into play.
So
where that could be the role of when the birth doula is starting to fade out, have a postpartum doula on board to be able to come do home visit, hospital visit with them, and might be a different role than the postpartum doula would have done if it were strictly all at home. But I think that's really, really important. So thank you. Yeah. So really, thank you so much. I'm thrilled for you that you will be moving forward into your clinicals for midwifery and becoming a midwife. But I also now feel really bad that you're going to be leaving the NICU just because it sounds like you really found a home and that, you understand you're part of what we want in that unit for people to have. So I hope you will be replaced someone who sounds equally as wonderful as you have been in that position. I wonder how this... I guess my last thought is, given that you've seen really intensely life-altering experiences through these babies' eyes, do you feel like that's how is that going to impact your midwifery at all? Do you think you'll have more fear of what could go wrong? Is that a fair question?
No, that is a fair question. My husband and I don't have kids yet. I think that actually is more factored into that.
Yeah.
Like, if and when we do have kids, which I hope we do one day. But I think that scares me more.
Gotcha.
Knowing what could go wrong. Like you could have a perfectly normal pregnancy, everything be beautiful, but you just never know. And it's very rare, but like you just never know. As far as being a midwife though, I'm actually super thankful because I have the training, and the expertise and the advanced skills to, handle a baby, that comes out and it's just not doing well. A lot of, student midwives that I'm in school with, most of them are labor and delivery nurses.
Right.
So, they say, I can deal with a postpartum hemorrhage. I can deal with a mom, whatever that is, but I'm terrified of the baby.
Right.
And I was like, well, I'm thankful that that's not the case for me. I mean, I will always be scared, but
sure,
I have the knowledge.
You have the knowledge, and also you have to have an amazing ability to stay focused and calm during that period of time, because you have to be. You have to be thinking on your feet what to do for this baby. So that's a great background. I hope you know how to deal with those hemorrhages since you haven't had
in school, midwifery school.
Yeah, no, just giving you a hard time there. Well, thank you so much for taking time this morning to come in and talk with us. I know this will be really helpful to our listeners. This is something, as I said in the beginning, people have asked questions about, and it's just really helpful to hear from the source. How things are done and how we can negotiate. So thanks, Sarah.
Yeah, you're very welcome. It's a pleasure being here.
Have a great day, and I'll be right back, you all. Thanks, everyone, for listening. I really enjoyed that conversation with Sarah, myself. I hope you did, too. I think there was good input and a nice oversight of how the NICU team can work and how you can work with them and with families and resources and so forth. And, of course, as already mentioned, you're going to have to look into your own facilities to find out what kind of NICU units they have. And I really do want to encourage you to do that. It's, you will find yourself in this situation, if you haven't already, sometime along the way. And better to know, if you can, prepare yourself so you can help prepare the clients for what they're going to have to negotiate. So the last thing I will say about our guest is, if you have specific questions for Sarah, please send them to us at ToRAISEQuestions@gmail.com, and perhaps we can get Sarah to give us some input on that for you, or if there were a lot of them, we could do a second recording with her, I'm sure, as well. So I hope everyone is taking care of themselves during this winter time. First, in your health, that you're getting plenty of rest. Yes, I'm your mother now. That you're drinking lots of water and other good fluids and foods, and enjoying life. I think also for our mind and our souls right now, we all are kind of involved in a tumultuous time, with no matter what side, quote unquote, you are on. I hope we all can remember that first we have to be loving and kind to ourselves, and then to pass that loving kindness on to others in our family, in our lives, and those people that we're not agreeing with, that we're feeling very compelled to create more conflict with. We really need to come back to our compassionate ways. I believe that we have the right to speak and act and resist what does not feel right and comfortable to you. But I think we can do those things with compassion towards everyone, because we were all once little babies, and we can't forget that. So on that note, take care of yourself, and I look forward to being with you again in the very near future. Bye now.